Okay, so today we are going to be talking about the team approach to healthcare. Remember, we are going to be acting as a team out there. It's not just the personnel on whatever apparatus you show up, right? Ambulance, usually you're gonna have you and a partner. If we're talking a fire crew, can have multiple, right? But there can, because there's so many people on scene, this can get a little tricky from time to time. So understanding how to manage these situations is gonna be huge. Now, where you guys are at in your careers, I would not expect you to be great at this quite yet. It's just kind of the way it is. It comes with experience, but we can kind of open some doors early, okay? So remember, first and foremost, you are a critical member of this healthcare team. Understanding that you have a role to play, and also understanding that your role is not always one in the spotlight is gonna make it important, or rather add value to what you're doing on scene. Okay, remember, you are there for a specific purpose. You are there to help out. Okay, so moving forward, key goal of EMS Agenda 2050, remember that's from chapter 1, is to ultimately make EMS systems safer, inherently safe, right? The goal of 2050's agenda was to essentially, let's figure out how can we make this field what we want it to be, okay? With safety being a big emphasis, as well as teamwork being an emphasis in there as well, okay? So part of that agenda, minimize exposure to injury, infections, illness, or stress, create a culture of safety, and then embracing just culture, which once again was brought up in chapter 1. Okay, so we are in the era of team healthcare. So community paramedicine, mobile integrated healthcare, right? MIH, that's gonna be more of your ambulance type crews. It's gonna be first responders, right? The ones who show up on scene. They're gonna be our best examples of team concepts, especially when it comes to continuation of care, especially that community paramedic side. Those are the folks that get out there. They kind of check on the patients that we need routinely checked on, right? Are these the folks that are mentally ill, so they need someone to just kind of check in on them from time to time? Or are these gonna be the folks who, you know, they're having a hard time getting a medication or something along those lines? So can we help out? Where can we help the community, right? So that's gonna be building a continuous care or a continuum of care. That way, if we can kind of solve people's issues early, we're gonna stop seeing them as often. Remember, EMS is about preventative care, okay? It's not just about being reactionary. Now, the structure and effectiveness of emergency healthcare teams differs from the system to system. It really depends on where you're at. We can only really speak to, or at least I can only really speak to, what Ada Counties has looked like. That said, I know that our team system works pretty well, okay? So wherever you guys land, that's gonna look a little bit different, just depending on the state, the area you guys are working in, okay? So, different types of teams. We have our regular teams, okay? So EMTs who consistently interact with the same partner or team. This is usually gonna be more of like your crew setup, okay? So your ambulance crew, a lot of times you'll have a routine partner you spend a lot of time with. Same with the fire engine, kind of similar lifestyle. You're gonna be with the same folks pretty frequently, okay? That's gonna be just our standard, typical EMS team versus our temporary teams, okay? So EMTs who work with providers with whom they do not regularly interact or may not even know. That can also be kind of an aspect of how team dynamics work, especially if you think about, you know, in our area here, the amount of fire engines to ambulances. There's a lot more firefighters than there are ambulance crews, so a lot of times we're making temporary teams, making sure that we can get on the same page in the same moment, as well as working towards being a patient advocate, okay, which we'll talk about a little bit further along, okay? As well as on that temporary team, that could include things like specialized teams, okay? It really just depends on the situation, what's warranted. So some specialized teams, we have fire teams, we have rescue teams, okay? Hazmat, tactical EMS, so things like your TAC med teams or SWAT team medics. You have event teams, so if we have like a large event like football games or big concerts, you'll have event teams showing up. Same with the EMS bike team, at least in this area, that tends to kind of go hand in hand with our event teams. If you think about like tailgating. In-hospital patient care techs, and then MIH technicians, right? Mobile integrated healthcare technicians, kind of what we are, right? Even though the MIH technicians, in my opinion, seems to be more of a regular EMT team. That said, you can be put into situations where you don't know people really well. At the end of the day, your job is to make sure we can get the best outcome for our patient, regardless of who we're working with. And sometimes that requires swallowing a little bit of your ego, okay? So, a group versus a team. So a group consists of individual healthcare providers working independently to help the patient, and they do this through 3 different methods: triage, treatment, transport, okay? Now for us as EMT basics, this is kind of our bread and butter. This is what we're supposed to be really, really good at, okay? Identifying, is this a life threat, yes or no? That's part of our triage. If it's going to be a life threat, what is our treatment? Is it going to be an appropriate treatment? It should be, right? Staying in your scope. And then is it the right treatment for what's going on in front of us? And then there's also the transport aspect. And remember, we are not definitive care, especially if we're talking about things like trauma. Trauma is a surgical disease. They need a surgeon. There's nothing we can do to fix the problem, but we can be a Band-Aid. Okay, so the transport is a big portion of what we do. Okay, so now a team consists of a group of healthcare providers who are assigned to specific roles and are working interdependently in a coordinated manner under a designated leader. This one you will see pretty frequently, especially as crews start to get really familiar with each other. For example, fire crews, ambulance crews, right? They are doing their own thing interdependently, but they're all coordinated. Everyone's got a job to do. The best example that you will see of this would be something like a cardiac arrest. Okay, if we have the paramedic who typically is going to be the one leading the call, then everyone underneath them kind of has a job to do, right? Someone's on CPR, someone's bagging, someone's getting meds, someone's making sure, the surrounding environment is safe enough. Someone's job, usually fire captain, is going to be getting demographics on our patient, okay? But we are going to be working as a team more often than not. Okay, so keep that in mind. If you're someone who's got a sports background or a sports mindset, you kind of understand how this works. For someone who has not had that kind of experience, you might have to identify some of your weaknesses and understand that, once again, we are operating as a team, so overcoming some individual bias or individual opinions might be something you have to accept, okay? Now, 5 essential elements of a group. Working for a common goal. They imagine themselves, or they have an image of themselves as a group, right? They're operating together even though it's temporary. They have a sense of continuity of the group. They have a set of shared values, and they understand they have different roles within their group. Now, if we go through each one of these individually, they all kind of look a little different, right? The common goal, especially if we're in EMS, is going to be patient outcomes, patient advocacy, okay? Always acting in the patient's best interest, as well as understanding if we're on the scene together with a group of people, then we have to understand the fact that we are the ones that need to get through this kind of together, okay? So that is going to be that group image, understanding that myself as a single paramedic am not going to get the job done, okay? Or I'm not going to get it done as effectively or as timely as I want it to be. We need to have everyone on the same page and understanding that we are in the same team right now, okay? Sense of continuity of the group, we want to make sure that, just because we're in a group now doesn't mean that as things progress, we're like, okay, I'm done, hands off. That's not necessarily the case, right? You are going to be involved for as long as you are needed. That's part of this field, okay? Now, a lot of the set of shared values, that kind of comes with a lot of folks in this field. A lot of us are very like-minded individuals who have a similar set of values, and especially as our departments work closer and closer together, that becomes far more integrated, okay? And then understanding, last but not least, the different roles within the group. Not everyone can be the leader, right? You can't have too many cooks in the kitchen at one time. So understand, just because you're there doesn't mean you're running this call or teching this call, as we will say out there, but you will have a role, and that understanding your role and doing well in your role is ultimately going to help our common goal, which is patient's best outcome, okay? So some different types of groups that we'll see: dependent, independent, and interdependent groups. So for dependent groups, each individual is told what to do, how often to do it by his or her supervisor or group leader, okay? So this is kind of thinking back to that cardiac arrest example, okay? Everyone has a role. They know what they need to do. That kind of ties into this interdependent group idea as well, right? Even though the dependent group is usually outlined a little bit more by a leadership area, Interdependent groups, everyone has their own job. They understand they have their own responsibility, okay? An example of that could be something, an example of that could be something like a hazmat team showing up on scene, right? Their job is to secure and lock down whatever hazardous material is going on versus the EMS crews, the fire crews, right? We're pulling the people out. We are managing the patient in front of us, okay? We're independent groups, but we're still, once again, working towards the same goal. And then last, but certainly not least, interdependent groups. So everyone works together with shared responsibilities, accountabilities, and a common goal. Now you'll notice that a lot of these kind of feel the same. It's because this is a very fluid field. A lot of these are going to integrate in with each other. Okay, so interdependent groups, right? That's once again kind of falling similar in my mind to the dependent group, just with the understanding you have a little bit more autonomy. You're going to be operating under what you know is your kind of your responsibility, I'll say. Okay, so for an effective team performance, once again, we want everyone on the same team. Best patient outcome happens when we are all working together. Okay, so we have a shared goal. We have clear goals and clear roles and responsibilities. We have a diverse and competent skill set, so we each have our own abilities. We each have our own kind of specialty area. We know how to effectively collaborate and communicate. And then we have supportive and coordinated leadership. Now, this happens pretty quick. Now, more often than not, at least from my experience being on the ambulance, leadership kind of, depending on who's on scene first, goes to who has the highest scope. If it's someone of a fire perspective, usually the captain's the one calling the shots, which kind of makes sense, right? But each of these are important to, once again, our best overall patient outcome. One thing that does need to be acknowledged, in my opinion, is that you're not going to get along with everyone. It's just the way it is. That's life, right? But can you get through a coordinated 20, 30-minute event as seamlessly as we can, okay? And part of that is, I don't want to say calling people out, that's not the right verbiage, but holding people accountable, okay? If someone's, for example, let's say someone has a broken or injured neck and a broken wrist, and the person on scene says, I want to splint this wrist, that is a priority. Well, we understand the neck is probably going to be the more dangerous of injury patterns. It is appropriate and okay to say, no, we're not doing that right now, okay? We're going to coordinate towards the biggest life threat, okay? It is okay to tell people no, as long as you're being tactful and you're understanding you're once again doing this for the patient's best interest, okay? So communication and team dynamics fostered from crew, resource management, and team situational awareness. Once you guys get out there and you've been in the field for a little while, you kind of get a sense of what's needed from you, and you also kind of get the sense of, you know, what the situation's warranting. Okay, now the longer you're out there, the more experience you have before you get on scene, typically will help. But that's, you know, that comes with time and experience, like I said. So just keep in mind, it's not going to be an overnight thing, but it will happen. You'll develop a comfort the longer you're in this field. Okay. So CRM recommends use of PACE mnemonics, so probe, alert, challenge, emergency. More so kind of paying attention to how you're interacting with different folk. Okay, so at what point is this, you know, do we just kind of check in like, hey, making sure that we are on the same page, okay, alerting them this is not what I want it to look like, challenging them, okay, this is going to be, and once again, challenging tactfully. This is going to be something where, you know, I don't agree with the medication plan or the treatment plan currently. What's our best route? How can we tactfully work together, kind of challenging the idea? And then the last one being emergency, where it's like, okay, this is now something we have to interact with, we have to deal with because we're starting to potentially hurt our patient's outcome, okay? So moving forward, transfer of patient care. Now remember, with patient transfer, it's always to an equal or higher scope of practice. Otherwise, we are running the risk of abandonment. So keep that in mind. Okay, we can't just hand off patients to anyone willy-nilly. Okay, so transfer introduces the possibility of patient care errors. It happens. Okay, as you're transferring patients and you're kind of moving things along, it's like the game of telephone when you were a kid. Everyone's on the same page as you're saying it, but sometimes the details get lost in translation. Okay, and that same kind of thing happens. Especially for us. I actually was talking to a nurse a few years back who told me that it was not uncommon for patients to change their stories 3 different times from the time they're dropped off by EMS to the time they're in the ICU. So understand this is kind of something we know is gonna happen. Doesn't mean we're not gonna try and combat it best we can, okay? So general guidelines for a smooth transfer. Uninterrupted critical care, right? Once we have our patient in the ER, we're going to integrate in as best we can with the ER staff there, ER physicians and nurses present. So once again, best patient outcome. Minimal interference, so if you can, try and get as direct access to the nurse or the doctor you're giving report to. Just the more time you spend away from this handoff report, especially as you're new, the more mistakes you'll make, the details will fall away. So make sure you're holding on to those, do what you have to be creative and remember that. I used to write some things on the back of my gloved hand. It wasn't always helpful if I got blood on my glove, but that was not as frequently as you'd think. So it's still a good option, but use whatever works for you, okay? Remember, respectful interaction, golden rule, treat others the way you want to be treated, okay? Especially in healthcare, especially when people are really tired, right? Working long hours, working hard. People tend to get a little bit snippy with each other. Remember, be respectful, dignifying. We're all on the same team here. Understand we have common priorities, right? Once again, patient advocacy, and then common language or system. So we talked about medical terminology on our Human Body Day as well. Medical terminology is great. It's something that, if you're talking to another person who's versed with medical terminology, they're gonna be on the same page pretty quickly. But also understand that plain speech goes a long way. Okay, sometimes it's better just to say the thing bluntly, the way you would normally say it, rather than trying to find a med term and then use the wrong term and now everyone's on a different page. Okay, so if you're unsure of what the term really means, just use plain speech and that'll help get you through it. Now, you guys are gonna be BLS providers. BLS and ALS are gonna have to integrate pretty closely, right? Now, depending on where you work, you might be a total BLS unit, you might be a total ALS unit. Here in the Treasure Valley, we are a bit integrated, so we have to work with each other. But the understanding that they cannot exist independently is kind of the reality, right? BLS saves ALS a lot, just like ALS can do more than BLS. So when needed, everyone has their responsibilities and their roles to kind of follow. Okay, so understand we have to integrate, we have to work together. So BLS efforts must continue through the continuum of care, okay? There's several stories I can kind of relay to you of BLS providers understanding, okay, I need to continue with BLS care when ALS is thinking up here and the answer is right here, okay? Sometimes you gotta really put 2 and 2 together, and this is where it's not inappropriate to, I don't want to say once again call people out, but hold people accountable, okay? Even BLS to ALS. Now, if you don't understand every procedure ALS is doing, that might not be a moment to open your mouth, right? But if it's someone who an OPA or an MPA would go a long way and the medic is really focused on one thing or the other, right? That can work in your favor. So understand we have to integrate closely. Okay, so what may be paramedic only skill in your EMS system may be common for an EMT to perform in another. A good example would be states like Washington. They can use iGels, which is at the basic level there. Here, advanced airways are going to be at the minimum advanced EMT level. Okay, so it really looks different depending on where you land, so make sure you understand your scope of practice, understand what your county or workplace require you, so once again, protocols, right? SWO's protocols. Now for you guys, assisting with ALS skills, okay? There's a 4-step process usually in here, so patient preparation, what can we do to get the patient ready for the skill that's gonna be needed to be done? So an example, if you're gonna have help put on a 12-lead EKG, maybe you go ahead and you start shaving the patient's chest early, right? Starting to think about what do we need to do to make sure this gets done effectively. The next one is going to be equipment. So more often than not, especially in my experience, I would have EMT basics go and set up like things like intubation. If I needed to intubate a patient, I'd tell them, hey, go ahead and set that up in the rig, we'll get the patient ready, we'll be out there, okay? Understanding the equipment and understanding what the medic's gonna want kind of comes with time and experience with that medic as well, but it is something that is questions worth asking, right? If you're going into a shift with a medic you've never worked with before, it could be worth asking, hey, how do you like this set up? How do you want that set up, okay? Everyone's got their little kind of nuances. Don't take it personally if it's different from what you want. Just understand we're there to help ALS, right? The next one, performing the procedure. Sometimes there are little things and tricks that can be used by BLS to help ALS with the procedure. Okay, things like if the ALS provider, paramedic's gonna be intubating a patient, if you put what we call crike pressure, you push down on the throat, or if you do a jaw thrust while they're intubating, that's gonna help them out significantly. Okay, now I wouldn't just jump in and be assumptive that they want that, but be prepared to the point that they're going to maybe ask, okay? And the last one, continuing care. So understand just because this is ALS, there's still gonna be BLS interventions more likely than not to be done. So where can you kind of handle that situation? Where can we step in as BLS providers and be a little bit more forthcoming with help rather than waiting on the paramedic's choice? There's one EMT basic I used to work with quite a bit, he was really, really good about thinking ahead of me and understanding, okay, well, if we're doing this now, then he's probably gonna want this later, okay? Example would be like, if I want an EKG, he knows I'm probably gonna set up an IV. So he would go ahead and he would do that for me. And it was really, really helpful. But how can BLS kind of think ahead of ALS is gonna help with that continuation of care, okay? Now, we are an EMS. You guys are all in school to the point you're trying to remember facts and memorize things, but a lot of it comes down to critical thinking, right? You guys will probably notice as our benchmarks progress through this course, they get less and less regurgitation of information and more, okay, here's the situation at hand. How do we critically think our way through this situation? What are they really asking for, okay? So just things to think about there. So effective decisions are based on sound, up-to-date knowledge, right? That's gonna be a lot of your protocol information. That's gonna be some self-study even, or maybe even CE's, continued education. What information is being provided by the patient, okay? We're not just listening to what they're saying, we're trying to digest what they're saying and find our outcome, right? We're not just listening to listen, thinking of our next question. We're listening and we're formulating, okay, this is the best treatment plan at hand, okay? Looking into the patient's history, it's gonna be another part of it, right? Critical thinking, if it's happened before, it can happen again. If I show up to chest pain and the guy tells me, yep, I've had 3 heart attacks in the past, this feels the exact same. Not crazy to assume that it's gonna be the same thing, right? So preemptively looking at that. And then getting a good physical exam, right? Especially things like trauma, if we have to put the pieces together. So-and-so patient has a broken femur, we'll say. How were they positioned in the car? What did the car look like as we pulled them out, right? If I'm finding the injury patterns, I'm matching it up with the broken car. We can kind of put things together, critically thinking, that might progressively lead us to our next treatment plan. Okay, things like a Sager splint or a traction splint rather for the femur, right? We can start making good choices based on the information in front of us. So some stages of decision-making process. There's the pre-arrival, right? So think about like your call notes, your dispatch notes. You are dispatched to XYZ at XYZ location, okay? We have what we think is gonna be accurate. Once again, take that with a grain of salt, but at least we have an idea of what we're showing up to. Okay, that's stage 1. Stage 2, the arrival, right? We show up, okay, this is what's actually in front of us. It's not entirely just dispatch's notes. We can start putting things together, or if the dispatch notes were a little bit inaccurate, we can start piecing together what actually is happening, okay? There's the during the call, okay? So we have to make some choices. What do we see in front of us? What are we gonna do, okay? And then there's the after the call. Now this one, more often than not, if you're gonna include after the call being dropping the patient off to the crew, or excuse me, the hospital staff, right? Making sure we're talking to the right people, we're making the right calls if we have to report anything. But even after the call, what does it look like? What are we missing and what are we gonna potentially need to replace? Remember, ambulances especially have to be replenished with supplies frequently. So what can we do as EMT basics to kind of plan for the next situation? What do we not have? What do we need that's gonna make us successful in the future, okay? Now, some traps. People kind of get into some different headspaces that can disrupt your critical thinking abilities, right? Things like bias, natural bias, okay? You know, I like this better because of this, right? Once again, we're in medicine. It's a lot of different opinions that kind of lead us to the same outcomes, right? You've heard the expression 1,000 ways to skin a cat. Same idea, okay? Don't let your bias hold you in there. There's gonna be anchoring, right? So you kind of latch onto this one idea. This is what you think is going on, and you're unwilling to break away from that thought process, okay? I think of anchoring, another way to describe that is going down the wrong rabbit hole, right? Not every chest pain's heart pain, but if you hear chest pain, that's what you do. That could be an anchoring kind of mentality, okay? And then overconfidence. This is one, especially in newer providers, that gets them in trouble, okay? Understand where your skill limit is, or skill line is. Not that we don't want to break past that eventually, but understand if you're a newer person, being overconfident can get you in some bad ways, and kind of ties back to that anchoring where we can go down the wrong rabbit hole because you're so confident in one thing that it's not actually what's going on. Okay, so maybe having some self-reflection and understanding of that is going to take you a long way. Okay? So, troubleshooting. Like I said, you're not going to get along with every single person that you're going to work with out as a first responder. It just is, that's the way life is, right? You don't like everybody. So, end of the day, patient comes first. We're always going to be patient advocates, always looking out for the patient's best interest. We have to be able to understand, are there moments where this is just not worth engaging with, right? If someone's going to start calling you names or acting unprofessional on scene, just kind of generally put, is it something that we're going to engage with, yes or no? Okay, you're going to have to make choices. I would definitely encourage you not to engage. It's something you can deal with after the call, right? That could be part of that critical thinking. How do we deal with this situation after the situation's happened? Okay, but you're going to have to make the choice. Remember, keep your cool, right? We live in a stressful environment, a stressful workplace. It's going to be part of the gig, okay? So cool, calm, collected, right? Be scared in your head, not on your face. Especially if you've got patients looking at your face, you want to kind of keep that back in there, okay? Can we separate the person from the issue? This is one, as a provider, that can be difficult. There's different ways to navigate that. I've had historically interactions with other providers where I've asked them, hey, we don't need you on this call anymore. You guys are good to clear, okay? It's all about tact and how we present that, but sometimes that's what you got to do. Or even from a different perspective, right? Like if we have to separate the patient from the issue, say there's a domestic violence type situation, or domestic violence, type situation, right? Can we have some of our crew separate off and keep the potential attacker, what's the word I want to use, guilty party to one side, and then can we keep the patient separate, right? But understanding as teams, right, we're going to have our roles, and can we keep that separate? Can we get on the same page? If it is something you're struggling with, once again, might be worth talking about after the call. And then choose your battles. Kind of falls into that do not engage, right? Not every battle is worth fighting. Not everyone's opinion is worth getting upset about. Okay, a lot of this stuff is just not worth your time or your mindset, right? Don't let things occupy your mind that aren't necessarily worth it. Okay, think about what's going to happen long term if we choose not to engage. Okay. So that's the review, or the chapter, okay, team dynamics. Just make sure when you guys get out there, spend some time in your protocols, spend some time with the crews around you and see how people like to do things. Get comfortable with different crews, and that'll kind of ultimately help you out in the long run.